All right, party people, we are back at it. Today, we're going to be going over how to use various screening techniques to understand what your patient is going through if they're suffering from TIAs. I see a lot of students messing this up. We're going to cover how to differentiate when to use the right screening tool for the right type of patient under the right circumstances. So as you can see on the screen, we've got brain MRI, we've got carotid duplex ultrasound, we have carotid angiography, Holter monitor, and transthoracic echo. All right, let's get it. All right, first things first, let's just understand that MRIs are not routinely done in the evaluation of strokes or TIAs. In theory, it can show the penumbral regions. Basically, these are areas of the brain that are ischemic but not yet infarcted, which can be useful in some situations where stroke onset is unclear, like a wake-up stroke, quote unquote. But just know for the USMLE, MRI is not the correct answer if they give you a patient with TIAs or strokes. And to clarify again, that in under 4.5 hours from the onset of a stroke, you give TPA. Over 4.5 hours, you give aspirin. For hemorrhagic strokes, you manage the bleed, so stop all anticoagulants, control blood pressure, etc. Basically, think of MRIs can be used for complex cases, but in routine assessments, this is not the move. All right, next up, we've got carotid duplex ultrasound. Now for patients with TIAs, strokes, or retinal artery occlusions and hypertension, this is key that this in fact is the first diagnostic step for carotid artery plaques that might embolize to the brain or the eye. So scenarios where you're going to roll with a carotid duplex ultrasound first. Number one, if your patient has normal blood pressure and the patient is older, for example, above 70, you do an ECG first, then follow up with a 24-hour Holter monitor to check for paroxysmal AFib. If the USMLE question doesn't give you blood pressure at all and just says something like older dude with a TIA, stroke, or retinal artery occlusion, that's when you pick carotid duplex ultrasound. But if the patient has recurrent syncopal episodes and no mention of blood pressure, then you have to get an ambulatory ECG monitoring Holter first to check for intermittent arrhythmias. This is extremely important. This is very nitpicky, but it is very important. Here's a bonus key point that's actually very relevant and very high yield. Just know that hypertension is the #1 stroke risk factor, even more so than smoking. Chronic systolic hypertension damages the carotid endothelium, and that leads to atherosclerosis. So if you're asked what's more important to prevent stroke, just know that blood pressure control beats smoking. Obviously, stopping smoking is still important, but when answering these questions, keep that in mind. Now, when evaluating for carotid stenosis, anything considered more than 70% occlusion in symptomatic patients or 80% occlusion in asymptomatic patients warrants endarterectomy. If the stenosis is below these thresholds, manage medically. Think antiplatelet therapy, aspirin, ACE inhibitors or ARBs, or statins. TIAs, strokes, and retinal artery occlusions by definition are symptomatic. And also please know that a carotid bruit is not a symptom. It is a sign and considered asymptomatic. Now, in terms of carotid angiography, in your own mind, just place that this should never be a first option. While it might be done prior to surgery to better understand the vascular anatomy, it's not your initial test. So start with that duplex ultrasound if given the choice. And back to that Holter monitor, as already mentioned, this is to be used if the patient has a stroke, TIA, or retinal artery occlusion with normal blood pressure, especially in the elderly, or syncope with no known cause, because you're trying to detect paroxysmal AFib. And this finally brings us to the transthoracic echo. This would be used after you've diagnosed paroxysmal AFib on that Holter. Then you use an echo to look for left atrial mural thrombi. And even then, a transthoracic echo may miss it. You often need a transesophageal echo to get a better look, especially when evaluating mural thrombi, vegetations, such as the case in infective endocarditis, or myxomas. Transthoracic echo is used for evaluating ejection fraction or left-sided heart failure, predominantly. All right, that's it. Go crush it.